Now I would like to invite Sir Uli Pato sir for the next talk on challenges in uveitis, overlappers and combined troublers.
Uh, I think I'm lucky enough because you have again showed some cases which I'll be briefly discussing. So this topic is very fascinating. I don't know how they decided. It's like such a I'm going to conferences for so many years, but nobody has asked me to talk on overlappers. So this is, I think, the most important part in our medicine or in our clinical practice also. So if you see the mistake we do in our clinic, no. So what happens under right circumstances? Certain condition will closely mimic one or another, and leading to a serious consequences. And you will realize that, oh, I should have thought about it. So I'll just go into little that psychological part of it, that why it happens. So if you see that there will be always a pattern recognition and anchoring bias, we call. So relying on the familiar patterns lead to the premature conclusion. For example, we see a patient of red eye and immediately we jump that, oh, it will be conjunctivitis. Then there is something called heuristic, like recently seen and commonly diagnosis. If you have seen some case in conference, or you have read about some entity, and in clinic you try to overdiagnose that. So there is a tendency for that also. And then there will be a confirmation bias, like tendency to focus on the evidence supporting the initial your assumption rather than the conflicting ideas. So that's what I call that falling in love with your diagnosis. You don't try to understand that there are certain features which are not matching with your diagnosis, but you try to focus on what are the features which is matching with your diagnosis. So that is called confirmation bias. And then there will be a cognitive load. When you are in a busy OPD, you are stressed, you are highly tired. So that time these things will overpower it, and you will be like you are prone to do mistakes. And then the familiarity trap, that overconfidence in well-known conditions, because you have treated so many of these conditions, no, that sometimes you will do that while doing cataract surgery, you have done a PC rupture, and if you go think over a little that you are so familiar to it, you don't try to understand that, oh, I have to go slow here. And that's how we create mistakes. So the familiarity trap is the most important bias in such cases. Now you see this case already. Lekha madam has nicely shown you a case. It is much more simpler case, but this patient was diagnosed with VKH, and the patient was treated with IVMP and oral steroid. And finally, when the patient came, and you see it is bilateral. So when we did a fundus fluorescent angiography, you can see the leaks which are increasing in size and intensity in both eyes. So it was a very rare case of bilateral CSR. So these are the cases invariably you will miss in your OPD if you are not doing multimodal imaging, as she pointed out. This is another patient, a 43 years old male who presented with diminution of vision, gave history of oral ulcer, and there was a panuveitis, so diagnosed as Behçet disease. You know that oral ulcer is very common. Behçet ulcer disease, if you see, it is severely painful, but the common oral ulcer anyone can have. So these patients were diagnosed as a Behçet disease, started on immunosuppressive azathioprine and the corticosteroid high dose from in elsewhere, and patient developed severe eye pain, developed RD. That eye became pre-thysical and came to us when he started developing the involvement of the other eye. So that's where we realized that it was a case of acute retinal necrosis. So sometimes this kind of severe vitreitis, and where you can't see the peripheral retinal retinitis properly, and the patient gives you a history of that, okay, I have oral ulcer, frequent oral ulcer, so you tend to miss this mistake. There is a very important article in Vigio, you can go and read about it. So the second most mistake we do in Behçet's and acute retinal necrosis if we are not careful. Now, the third and the most important overlapper is the panuveitis and endogenous endop, because it is, you have to be very, very careful ruling out that. History taking is very important in ruling out such cases of panuveitis versus endogenous endophthalmitis. So the main is any cases of panuveitis, you have to be very, very careful before starting aggressive medical treatment. Now, tips to overcome the overlappers, the stop treating the clinical signs. For example, in first case, why we did the mistake, we try to treat the exudative RD without knowing the root cause of the exudative RD or the SRF in the fundus. The subretinal fluid in the fundus was because of the CSR, not because of the VKH, but we did not try to delineate that cause and tried to just treat that SRF, and that's why we did mistake. So clinical signs should not be treated. Go to the root cause, why that clinical sign is occurring. Don't fall in love with your diagnosis. Always question yourself, am I right? Am I doing any mistake? Some cases require special attention in time. If you are too busy, advise some imaging, call the patient in a day where you are relatively free, revisit your diagnosis. So that is important. And remember, patient may lie. That happens, so don't believe patients entirely. And something you have to understand, just because a patient does not have a history of a particular condition does not mean that it can happen. Every disease has a first occurrence. For example, we take a history of COX, contact with the COX. No, it's not there. That does not mean that the patient cannot have a COX. History of high risk behavior. In many patients in a sophisticated OPD, they will be reluctant to tell you about their behavior and all. So you should not take those things. You have to order. For example, TPHA, you have to order in all patients with any cases of uveitis, because syphilis is a great masquerader. So don't go by patient's profile that he is looks like he is a posh, he is very aristocrat, he denies any kind of high risk behavior. So we should not advise that. So don't fall prey into those, and cast a wide net of possibilities and avoid zebras, but keep them in mind. Now the zebras, if you know, it's an American medical slang for arriving a surprising and exotic diagnosis. So it is said that the professor Jonathan used to tell that when you hear hoofbeats, think about horses, not the zebras. But in uveitis is such an entity. Here, when you hear the hoofbeat, you have to always remember that it can be zebra also coming to your OPD. So that is very important. For example, I'll show you this case. A young lady with a history of diminution of vision for 1 month, history of headache and fever she gave. Remember, this history of headache and fever was there. Fever was recurrent, and there was a history of headache. And this was the optical coherence tomography photograph. You can say multilobular septi with subretinal fluid. And this was the picture fundus photograph, which is showing pinhead leak. And you can see that there is a placard pulling of the dye. So immediately I jumped into the conclusion that, oh, it can be a VKH only. So only thing helped me is that I just looked at her and she was very cachectic and looked very pale, and which bothered me is that why there is a recurrent history of fever. So fever should not come so often in VKH patients. So what we did, we just did a peripheral blood smear as I was showing, and it showed 95% blood cells. So she was referred to the hematologist and diagnosis of acute myeloid leukemia was made, and patient was started on chemotherapy. And if you see here, this is the condition. Here it looks like a VKH, but this FFA picture is often deceiving. You see the list of entities, and you note here that so many masquerade syndromes, the leukemia, lymphoma of the uveal tract, metastatic carcinoma, all they can have pinhead leak and placard pulling. So sometimes if you are very sure that it is, oh, they are VKH, just think about it, that are you missing something? Now, coming to the combined trouble, I'll only show one case because it will be beyond the time limit for this discussion. This is one of the best combined trouble case I have managed. A 35-year-old male presented with history of blurred vision, and the patient was treated with intravitreal bevacizumab, oral steroid. There was a quite AC, few cells in the anterior vitreous. I took the detailed medical history, and the history revealed that there is a two-year history of primary infertility. The semen analysis of him revealed azoospermia. And the patient also gave me history that in his earlier childhood, there is a history of exposure to TB when his uncle was suffering from tuberculosis of the bone. Now, with this picture, we just investigated the patient. Montu test was highly positive, quantiferin was negative, and as you can see, the serum AC is raised and serum lysozyme is within normal limit. Now, we did HRCT, and a radiologist called me that we need a bronchoscopy to confirm that, which patient refused. You can see here, mainly the patient's HRCT was showing mediastinal and hilar lymphadenopathy. I'll just take 1 minute and wrap up. So, ultrasound Doppler showed again some epididymy orchitis. Again, the urologist told you have to go for a testicular biopsy. The patient refused both the biopsy. So we are in a point where where we have a tuberculosis in favor, we have positive MON2, history of contact, endemic area, genitoury involvement is more common in TB, whereas sarcoidosis, the HRCT is favoring a diagnosis of sarcoidosis, raised serum AC, and ONH granuloma was more common. So what we do, we took the middle path. We started the patient on ATT and also started the patient on high dose of steroid. And at 3 months, you can see the vision improved significantly. 6 months, his he was oligospermic on repeat semen analysis, and he informed us about his wife's conception. And after 4 years, this patient every year come to my OPD from Calcutta to see and give a sweet because, and after 4 years, when I saw him recently, his second year kid is 6 months. This is another, just I want to show another patient of retinal vasculitis I published with Ashad and Hashali. What is the lupus? There is the rheumatoid arthritis and the lupus combination of both. And this is a NITUS publication where not a double trouble. It was a case of retinochoroiditis which presented with syphilis, tuberculosis and human HIV infection. So ground rule for tackling combined inflammation, believe that overlap of clinical condition can happen. Always keep a high index of suspicion. Syphilis and HIV, always investigate for both if one of them is positive, and take care of multidisciplinary approach if you want to tackle the combined troubles, and in case of doubt, always take a second opinion. Thank you.
Thank you, sir. Thank you, sir. Beautiful presentation, as always.